Let us know, Sam. Well, looks like we're live. Is that right?
Yep, you guys are all set.
All right, I am going to start then. We are now broadcasting. So hello, everyone. Welcome to the American Indian Cancer Foundation's Lung Cancer Webinar Series. Today's webinar is titled Primary Prevention, Screening, and Early Detection. My name is Misha Leffler. I am the Cancer Equity Coordinator here. I am a Bay Mills Ojibwe Indian community member. Today we have partnered with the American Lung Cancer Screening Initiative. We are very excited to have them here with us today. Before I begin, I just want to say that we are always open to questions. So if anyone has questions, please feel free to put them in the Q&A box or into the chat, and I will do my best to check them out as we're going through the presentation. So our presentation again is on primary prevention, screening, and early detection. So for those who do not know, the American Indian Cancer Foundation is a national nonprofit organization established to address the tremendous cancer inequities faced by American Indian and Alaska Natives. Our mission is to eliminate cancer burdens on American Indian and Alaska Native people through education and improve access to prevention, detection, treatment, and survivor support. So today's objectives include providing a brief overview of primary prevention from an Indigenous standpoint, discuss screening and early detection, and then identify ways to speak to patients about lung cancer screening options. So as I mentioned, we are partnering today with the American Lung Cancer Screening Initiative, and now I will have all of our speakers introduce themselves.
First of all, thank you so much for having us. We really appreciate the opportunity to talk about lung cancer and lung cancer screening. And my name is Alex, and I'm here today with Winston and Dr. Yang, who is a thoracic surgeon at Massachusetts General Hospital and faculty at Harvard. And together we lead the American Lung Cancer Screening Initiative in trying to identify ways that we can increase lung cancer screening and help communities learn more about lung cancer. So I think, is it okay if I share my screen for the presentation? Or do Winston and Dr. Yang have anything to add?
Just that we're very excited to be here. Thank you for the opportunity to share our experiences.
Awesome. Okay, cool.
Hang on. Did you have a couple more slides in the deck, Misha? I think there might have been.
Yeah, I think I only have one more slide, and then
go ahead.
Over to you. Yep.
We're just too eager.
Yeah, I get it. I understand. I'm happy about that. So from an Indigenous perspective, prevention looks like utilizing traditional medicines, having a natural diet, having a connection to nature, being connected, of course, to our community and our traditions, and then having some kind of daily physical activity and rest. We know that our Indigenous lifeways are prevention, and they are really rooted on these values that you'll see around the turtle that include a nonlinear relationship with time, our lifeways rooted in culture, balance, respect for all living things, sustainable and interrelated. So our ancestors recognized that our lives are sacred and how we take care of our bodies is important. So as I mentioned earlier, some of these prevention activities include using traditional medicines, consuming a natural diet free from processed foods, maintaining daily physical activity and rest, engaging with the community in traditional activities, and another one, but I can't see it right now. Connecting with nature, yes. And so we have a prevention and policy team here who focuses a lot on some of these activities in our community. So if you're interested in learning more about what ACAF is doing, you can reach out to them. My team, Cancer Equity, focuses on the ones along the bottom here, which includes staying up to date on vaccinations, helping people seek regular medical care, practicing safe behaviors, and then scheduling those regular preventative screenings. We are very grateful to have ALSCI now present on what some of these look like from the healthcare standpoint. So I'm going to stop sharing my screen now and turn it over to you.
Awesome. Thank you so much for that wonderful introduction. I will share my screen. Just a second. Cool. Can everyone see my screen?
Yep.
Cool. Awesome. So I kind of already briefly introduced our organization and who we are, but just to reiterate, I am here. My name is Alex. I'm here with Winston. I'm here with Dr. Yang, and together we lead the American Lung Cancer Screening Initiative. And so just to provide quickly a brief background to who we are and what we try to do as an organization is, so back in 2018, we created our nonprofit with the goal of raising awareness about lung cancer and lung cancer screening. So our goal as an organization is to want to raise awareness about lung cancer to help prevent it, and to raise awareness about lung cancer screening to help catch more lung cancers at an early stage when the cancer can be treated and the prognosis is good. And so a lot of our outreach efforts are focused on, one, identifying the reasons why lung cancer screening rates are so low, two, teaching people about lung cancer and lung cancer screening, and then three, most importantly, actually helping people get screened for lung cancer. So what we can see here is that lung cancer is very common, and many of you probably know someone who has or has had lung cancer. It's actually the second most common cancer in the US behind breast cancer and is the most fatal. So this graph estimates new cancer cases in 2020 for the 4 most common cancers. As you can see, 228,820 people will be diagnosed with lung cancer in 2020. To put those numbers into perspective, it's estimated that about 6% of people will develop lung cancer in the United States at some point during their lifetime. This translates to about every 1 in 15 men and 1 in 17 women will be diagnosed with lung cancer. So unfortunately, not only is lung cancer very common, but it's very fatal. And so in 2020, lung cancer is expected to claim the lives of 135,720 people. This graph shows the American Cancer Society estimates for the number of cancer-related deaths in the United States. So as you can see, lung cancer is far more fatal than breast, prostate, and colon cancer, causing more deaths than all of those 3 combined. And something that not a lot of people know about is that every year, more women will actually die from lung cancer than breast cancer. So lung cancer is very common and it's very, very fatal. So we can see that it's common and it's fatal. And you may be asking yourself, why is lung cancer so deadly? And one of the primary reasons why lung cancer is so deadly is because most of lung cancers are diagnosed at a later stage, stage 3 or 4, when it's much more difficult to treat the cancer. So this graph is looking at the proportion of patients with lung cancer by stage. Stage is a way for doctors to classify a cancer's tumor based on tumor size, if the cancer has spread to the lymph nodes, and if the cancer has spread to other locations in the body. Currently, most lung cancers are diagnosed at stage 3 and 4, when the cancer has spread beyond the site in the lungs where it originated. So this graph is based off of data from 2004 to 2015, published by the National Cancer Institute. As you can see, about 23% of patients are diagnosed with stage 1 lung cancer when the treatment options are the best, but about 65% are diagnosed with stage 3 and 4 when there's a lot less treatment options and the prognosis is unfortunately not as good. So what we can see here is a direct relation between the stage of diagnosis and their survival. For patients diagnosed at stage 1, their survival is much higher, like 82% for stage 1A. But as you can see, as the stage progresses, there's a significant decrease in 5-year survival. So that's our brief introduction about kind of the landscape of lung cancer in the United States. And Winston, I'm going to turn it over to Winston to provide a little more information on lung cancer in Native populations.
Okay, thanks, Alex. Everybody can hear me all right? Okay, cool, thank you. So a little bit in terms of information specific to the Native population in the US. These are some publicly accessible statistics. We just took the time to condense them a little. Long story short, Native American men and women will actually bear a higher cancer burden relative to the rest of the US population. We'll get a little bit into that a bit later on in this discussion, but the key takeaway is that men and women respectively are 12 and 6% more likely to get lung cancer specifically than non-Hispanic white people. Along with that, lung cancer is the leading cause of cancer deaths in Native populations, as Misha said during her introductory slides. All told, that's about 1,400 lives per year. Of the lung cancers that are found in patients between the ages of 60 and 79, it's like 64% of all of those cancers were in that age group, which means that your elders are the folks who are the most at risk for both developing and being found to have lung cancer. I make that differentiation because, as we'll get into a little bit later, just because the cancer hasn't been found yet doesn't mean it's necessarily there. So it's important to keep an eye out for certain populations, which is part of where screening comes into play. And we'll get a little bit more into the details on that later. Yeah, so this is just a sort of a visual to help folks understand a little bit more what that burden looks like. So in the 6 to 7 million Native American and Alaskan Native population in the US, there's approximately 16,200 cases of cancer per year. That's just going off of the last few years worth of data. Within those cases, about 2,400 instances of lung cancer will occur. So that is represented by the blue figures out of that total set of figures. That will be the new cancer diagnoses every year. So just doing the breakdown for the math, that's the 2,400 cases. Now, approximately 10,000 new cancer-related deaths every year occur in the Alaskan Native and Native American population. So within that 10,000 set, about 1,400 of them will be due to lung cancer, specifically within all the other kinds of cancers. So within this graphic, the brown figures will represent the new deaths. These are not insignificant numbers, and with screening, many of these can be prevented, or at least we can get some more lifetime back. So you can go ahead and the next slide. So in terms of keeping an eye out for the presentation of lung cancer, so how your loved ones may actually, or you even may seem to have certain symptoms, those would be things like a chronic cough. So let's say you've been coughing for a while, you go to a physician or your local healthcare provider, they give you some antibiotics. That doesn't seem to really make much of a difference. That's something to keep an eye on. There could be many causes, but lung cancer is one of the possibilities. Another common symptom or presentation is coughing up blood. That's due to the damage that occurs to the lung cancer to the lung tissue from the cancer. Shortness of breath is another common one because your lungs will have more trouble efficiently getting air in. And then recurrent respiratory infections. So that sort of goes hand in hand with the chronic cough. And then another common symptom, this is a little bit more on the extreme side, but sudden or unexpected weight loss over a fairly short period of time. Like we're talking weeks to months, not like over the course of a year. So. And just in terms of the general population, like we've already discussed, lung cancer is quite prevalent. It occurs fairly frequently. There's a number of risk factors, which we'll go into a bit later, but nearly 250,000 people will be diagnosed each year with lung cancer. And as we've already touched on, it can be quite an aggressive cancer, but it's also treatable. And so many of the diagnoses that are made are at a later stage. We'll discuss that a little bit as we get into some of the trials that are out there that help give us evidence for why screening is important and why it will actually make a difference, which Alex is going to talk to you about now.
Awesome. Yeah, thank you. So one of the best ways that we can improve the survival for lung cancer is through lung cancer screening. And so there's been several studies published that have supported lung cancer screening and detecting lung cancer early. And one of the first really big ones is the US National Lung Screening Trial. So back in 2011, there was a large national study with over 50,000 patients called the US National Lung Screening Trial. And the goal of this study was to determine the effectiveness of using a low-dose CT scan, which is how you screen for lung cancer. It's with a low-dose CT scan, and trying to determine the effectiveness of using this to detect lung cancer in patients considered high risk for lung cancer. And so what the study did was it looked at 53,454 current or former heavy smokers between the ages of 55 and 74. And then it split this patient cohort into two separate groups. One of these groups were screened for lung cancer using the low-dose CT scan, and the other group was screened for lung cancer using a chest X-ray. And so then the study compared patients who were diagnosed with lung cancer by the low-dose CT scan to patients who were diagnosed with lung cancer by the chest X-ray. And importantly, what they found was that of the patients diagnosed in each group, the low-dose CT scan was better at detecting more lung cancers early. So what we can see here is the people in blue represent the patients who are diagnosed with stage 1 lung cancer. And so what we can see is that the low-dose CT scan diagnosed stage 1 lung cancer in 50% of the patients, while the chest X-ray only caught it at stage 1 in 30%. So we can see that the low-dose CT scan is better than the chest X-ray at detecting more lung cancers early. And so this graph kind of illustrates that idea a little bit better, demonstrating that the percent of patients diagnosed with stage 1 lung cancer by the low-dose CT scan was a lot higher than the amount diagnosed with the chest X-ray. And then actually the chest X-ray caught almost 40% of these cancers at stage 4. So what we want to see is that that lung cancer screening detects more lung cancers at an early stage, which is exactly what we see with the low-dose CT scan. And you might be wondering that trial was from 2011, or it was published in 2011, which is 9 years ago. And importantly, very recently, just this last February, there was a new trial, or the results were published from the Nelson trial. And the Nelson trial looked at 13,000 men and 2,600 women between the ages of 50 and 74. And they were randomized to receive low-dose CT screening at a baseline visit at 1 year, 3 years, and 5.5, every 1 year, 3 years, and 5.5 years. And so one of the first takeaways from this trial is that it confirmed the results of the National Lung Screening Trial. It showed that there is a significant reduction in mortality due to lung cancer when you screen for lung cancer. And specifically, this demonstrated that there was a 24% reduction in mortality in men and a 33% reduction for mortality in women. Another thing was it actually improved upon the results of the National Lung Screening Trial, significantly reducing the false positive rate. So for reference, the false positive rate of the National Lung Screening Trial was about 6.5%, and the Nelson trial reduced that by about 3 times, which is really important and shows that in recent years with increasing technology, that lung cancer screening is becoming more accurate, which is important. And so this graph just kind of demonstrates the results of the Nelson trial. And so as you can see in the lung cancer incidence, there was initially a significantly higher amount of lung cancers detected in the screening group. And this is just because it was actually catching the lung cancer, and it was catching it earlier than the control group. And what's really important and really exciting is that in graph B, we can see that the patients who are getting screened had a significantly lower mortality rate, which is essentially why we are the American Lung Cancer Screening Initiative, because screening has been shown to save lives. And so currently there are guidelines that the United States Preventive Services Task Force has put out to, this is the patient population that should be screened. And so this is similar to other screening cancers that say like colon cancer, once you hit 50, or breast cancer, they have the patient population that should be screened For lung cancer, currently the guidelines are if you're between the ages 55 and 80, if you have a 30-pack year smoking history and you're a current smoker or have quit within the past 15 years, you are considered to be high risk by the United States Preventive Services Task Force. And this means that most insurances will cover lung cancer screening for this patient population. It is pretty important to note, though, that these guidelines are in the process of being updated as more trials come out and as more results come out demonstrating the effectiveness of lung cancer screening in reducing mortality. These guidelines are expanding to include more people. So in July, they released a new draft recommendation lowering the screening age from 55 to 50 and the pack year smoking history from 30 to 20. And so while these are currently not the current screening guidelines, I think in the next year, we will see these come into practice. So that's a brief overview of the major trials that have come out in support of lung cancer and lung cancer, or not in support of lung cancer, in support of lung cancer screening and the current guidelines. And now Winston, I'm gonna turn it over to Winston to go over a pack year and some more information regarding lung cancer screening. And actually he's gonna share his screen, so I will let him share his screen.
Okay, so can everyone see the slides all right? Okay, cool. So thanks so much, Alex. That was awesome. Just want to go over a little bit about what exactly pack year means, and then we'll get into a little bit more of how to get screening, a little bit about why it's more difficult for American Indian populations, and then we'll also talk a little bit about preventative measures. So we'll rehash a little bit about what we talked about in the lightning webinar with commercial tobacco cessation, but I'll go a little bit more into why it actually matters, aside from obviously stopping smoking. So in terms of what's a pack year, like Alex mentioned, your smoking history, like how much you smoked with time, is important to the clinical decisions about how you should get screened or whether you should get screened. But obviously this doesn't take the same appearance for everybody. Different people smoke at different rates. And so as healthcare providers, we try to normalize that through what's known as the pack year. So as part of this process, like a pack of cigarettes is assumed to have 20 cigarettes. So 1 pack per day would mean you smoke about 20 cigarettes in a day. And then we adjust that to how long you've been smoking for that amount. If you change the rates at which you smoke with time, you may need to add up different chunks in different ways. But long story short is that you could, as for instance in this graphic, get 2 30-pack years by different ways. So if you smoke more frequently over a shorter period of time, that would have the approximately same cumulative effect as smoking less over a longer period of time. So it's important for you to be a little cognizant of how quickly you're smoking, if that will eventually become a concern. Overall though, at the end of the day, what's really key about this is stopping smoking, which is the primary cause of lung cancers that we are aware of in the thoracic field, and then getting screening, even if you're not necessarily stopping. Neither of these things are mutually exclusive. It sort of takes every step of the process, bringing it together. And like Misha said, also returning to more traditional life ways, being more in tune with your family's practices, basically, and your ancestors' practices. And so going a little bit more into how you can get screened and the considerations that healthcare professionals should also have. So in terms of insurance coverage, screening is covered by a broad range of insurance programs. It's covered by federal programs like Medicare and Medicaid. It's also covered by many, many private insurances, because across the board, just based on these trials, many insurances, the companies, as well as the healthcare providers, have realized that everybody benefits from screening. It reduces long-term costs, improves lifespan, reduces burden later on in life. So everybody has something to benefit from this. So as you can see here, however, there's a bit of a hitch to that. which is that there are significant disparities between smoking populations and non-smoking populations, but also who has access to screening. So as you can see here, the American Lung Association has helped with some research where they worked with the American College of Radiology to figure out how offices are distributed around the country, radiology practices, things like that, places where people can get this important screening. And as you can see, there are many states, especially in the Midwest and Southeast, that are lacking in the capacity to provide screening, especially relative to the risk of the local populations. So smoking is not as common in California as it is in, say, West Virginia, which is one of the states that has the highest rates of smoking. However, the distribution basically of lung cancer screening centers, which you can see in this graphic, is significantly weighted away from not away from certain areas, but there are just many areas that are lacking in coverage. So this was a study performed by a group out of Mount Sinai Hospital in New York City, actually, where they worked with the data that the American College of Radiologists provides. And they went ahead and plotted all of the accredited locations with the American College of Radiology. However, one thing I'd like to note is that this is quite a big list. They had about 3,700 centers that are plotted on this map. However, there are more low-dose CT screening locations than just the ones that are accredited by the American College of Radiology. That doesn't mean they're less capable, but not everyone is accredited under the same guideline. So even if you don't necessarily see a dot in your area, you should definitely look to see what centers are available in your region. So this study basically looked at the way that screening facilities were distributed relative to population density, and in particular, the population of at-risk individuals. So that's people who were current smokers over age 45. And as you can see, there are clear disparities in where these healthcare offices are located. More often than not, they tend to cluster, as you can probably tell, around major urban areas, large cities in Texas, California, New York, the Pacific Northwest. But there are other centers around, and these folks grouped basically states into 3 different categories. And as you can see, there are states that are outlined in black, states that are outlined in green. Sorry, I'm looking at a different screen. This seems a little weird. But states that are outlined in green, and then states that are outlined in red. Now, this isn't a relative scale of states that had better or poorer distributions. All that they did was approximate geographic locations. But what they found is that for the states that are in red, so like I mentioned, those Southeast states, those states tended to have higher distributions of at-risk populations, so higher distributions of smokers, particularly older smokers, than many of the other states. But they also, relative to that, had the lowest distribution of accredited screening facilities. Interestingly enough, as you can see, one of these states is actually, the state itself is colored in red, and that's Utah. Utah had both the lowest incidence of lung cancer, the lowest mortality due to lung cancer, but also the highest number of screening facilities relative to the at-risk population. Part of that has to do with the distribution of smokers in Utah relative to other states. But that's just an example of what a state could look like if it were to have a low number of smokers with a high number of screening facilities for those at-risk people. So one takeaway for us is that down the road, it's important to be lobbying for increased access in at-risk areas for at-risk populations. And also raising awareness of screening, because the more the community lobbies for these resources, the more they'll be heard. So just to discuss a little bit more about what can potentially predispose you to having lung cancer, there are some secondary risks. Smoking, commercial tobacco, is still the primary risk for lung cancer. But along with that, things like exposure to secondhand smoke. So if you are frequently exposed to the smoke that someone is exhaling while they are smoking, that can put you at a higher risk for lung cancer. If you have a genetic predisposition, there are certain mutations. That's something that we'll get into in our next part of this series. But there are certain mutations that will put you at greater risk for developing lung cancer and can also change how aggressive it is. Other lung diseases like interstitial lung disease. Also occupational exposure. So if you're a firefighter, if you're routinely fighting brush fires or work in certain kinds of factories, or if you had exposure to asbestos through construction, that can also increase your likelihood of developing lung cancer. And another thing that we've discussed is radon, certain types of gases, radon and freon, things that are used for refrigeration units in the past. Exposure to those gases can also put you at a higher risk. So now I'm going to talk a little bit about how one actually gets screened. So what is low-dose CT? What is the relative risk of getting a low-dose CT scan against other types of imaging? And why it's useful to us as clinicians, and why we would prefer that people get this kind of screening. So the most important basic information for healthcare providers to convey to patients, but also for patients to understand. Low-dose CT is not a scary process. It won't hurt you. It's very quick. So basically you will lie down on this bed. It's motorized. It will slide into that sort of donut there. And that's how you'll do your imaging. I'll talk a little bit more about the actual process itself in a second, but it's very fast scan. It takes less than 5 minutes. It does not hurt at all. You shouldn't need to be injected with any sort of dyes or contrast agents. So overall, it's a great tool in terms of how little effect it has on the patient versus how much information it gives us as clinicians. So what do you expect from a CT scan? Well, the technology CT scans for computed tomography. I'll talk about what that means in a minute. They're colloquially known as CAT scans. You might have heard them referred to that way. But basically, they use a bunch of x-rays that they take and then compile together. And it will give you an image that looks kind of like this. I'll talk a little bit more about what that means in a minute. But this is a breakdown of how the CT machine works. Basically, there's the same type of thing that takes an x-ray photograph. It will take many, many x-ray photographs as it circles around the patient in a certain portion of their body. So in this case, it's a pelvic x-ray, but for our or pelvic CT, but for our uses, it would be chest CT, so that we can examine the lungs and other parts of the chest. And basically, it makes a number of rotations to take these photos. And what you end up with, also, I know this graphic's a little on the older side. It's 2002, but they used this during my engineering degree, and honestly, it made the most sense out of any picture I've seen since. So bear with me. But as you can see here, there are a number of slices made digitally. That's how these X-rays add up. So if you can imagine, you take one X-ray of the front, and then you tilt the camera a little bit to the side, and you take another X-ray. Little by little, you'll start building up these layers. And this is where the computed part of computed tomography comes into play. The computer basically takes all of those X-ray images, an example of which you can see on the left, and stacks them together and generates a three-dimensional image that you can scroll through. Unfortunately, I wasn't able to quickly find an image that allows you to see the scrolling, but I also didn't want to make it too complicated. It looks really strange if you haven't seen it before. But as you can see on the left, this is just a normal X-ray, just taken from the front on view of the chest. As you can see, the individual, that little L marks their left side, and those little white dots are like heart monitor leads, basically. So you don't need to worry about those. What we're primarily interested in here is where those two little arrows are pointing, which could be a lung cancer. As you can see, though, it's sort of hard to differentiate from other structures in the chest. It could just be a little bit hazy. This is the type of thing that as a clinician would make you a little suspicious that maybe something's going on in the person's chest. But this is also why X-ray versus CT matters to us. As you can see, there's not too much we can tell. It's a little bit hazy, but there's not much other information. And the key thing is depth perception. In a two-dimensional X-ray, you couldn't tell where in the individual's chest this nodule is. You can't tell how big it is. All you can see is one face of it. And so in a CT on the right-hand side, this is a different location. It's a different image. But basically, you can see that we now have a different view. And as you can see in this image, we can actually have several different approaches. There's 3 different ways that we can look at a person's body, and that will give us a lot more information about where this nodule is located, you know, how big it is relative to like one view of it from another side. And one thing I think Alex mentioned that had to do with the difference between the Nelson trial and the NLST was that the Nelson trial actually used CT images to find the volume of the nodules in the patients, and then over the course of those timed studies actually investigate how much larger the nodule was getting, if it was growing at all. And that's a big key off for us as clinicians about whether this might be a cancer or just some sort of benign nodule. If it grows with time, that gives us a lot more information. It's also something we'll talk a bit about later. That'll be in our next webinar series about how you deal with lung cancer with time. Now, if you're taking a bunch of X-ray images, like many of them, I'm sure that would make folks concerned about how much radiation exposure you're getting. So let's talk a little about that. You don't need to worry too much about what an actual millisievert means. It's a way that we use to measure radiation exposure. So one chest X-ray, like you saw on the preceding slide, that would be between 0.06 and 0.25 millisieverts, small number. So what's important though is that over the course of a CT, a regular CT, not the special screening kind, because you're taking all of those X-ray images and stacking them together, you'll get a greater exposure. That could be between 3 and 27 millisieverts. However, with low dose CT, you reduce the number of those images that you take so that those slices that we talked about, those get a little broader. So in effect, you take fewer images without losing your resolution. So you don't need to worry as much. Even though it's a lower dosage of radiation, they're not going to be missing nodules. It still has just as much diagnostic information. It's just better for the patient in terms of radiation exposure. Also, like we mentioned, you won't need contrast agents. So that's another thing that can change how much radiation the patient is exposed to in a given screening exam. Now, what do these numbers mean in the bigger picture? So you have a low dose CT that's at 1.3 to 2 millisieverts. That's actually quite small in terms of just what we're exposed to in daily life over the course of a year or something. So just the exposure that we have to cosmic radiation on the planet, there's 0.33 millisieverts right there, another 1/5 of a millisievert from just like Earth sources of radiation. There's particles in the air, we inhale that. That's almost as much in and of itself. So the positive benefits you get out of going for a lung cancer screening CT are significantly greater than even the minimal risk that you would get from that one radiation exposure. So now we'll shift a little bit more to the practical side of the screening, or I guess the patient-facing side. Basically, like I mentioned before, Medicare and Medicaid will cover annual lung cancer screening tests for the eligible patients. We'll talk a little bit about the guidelines. Most insurance plans will also cover the cost, but there are a couple important caveats. So for one, Medicare will only cover you up until the age of 77. Once you pass that age, you may need to use a supplemental insurance source for Medicare. Additionally, since Medicaid is state dependent, you will need to check state by state, whether you're a provider or a patient, to see what your state's Medicaid program covers. We'll have a brief graphic on that in a moment though. One other thing to note is that patients may still need to pay the usual fees for provider appointments before or after. Why is this important? Well, you have to go over the scan with somebody. You need to meet with your primary care physician, or if you work with an NP at a local clinic, a nurse practitioner, they can go over these exams with you, but you do still need to review the exam with someone and discuss the findings with them. Now, in terms of Medicaid coverage, as you can see here, the majority of states are fee-for-service covered in terms of lung cancer screening. There are a few exceptions to those. So that's something for you to figure out with your local clinic. Also, the Medicare guidelines slightly differ from what Alex discussed before in terms of what the Preventive Services Task Force actually recommends. So for one, under Medicare, the screening program is covered by Part B. and you get one screening exam per year. That covers patients ages 55 through 77. They can't currently have any signs or symptoms of lung cancer. So like I discussed before, coughing up blood, sudden rapid weight loss, things like that, that may preclude you, but that's something to discuss with your care provider. Also, you need to be a current smoker or have quit smoking in the last 15 years. And then like we discussed before, your cumulative smoking history must be at least 30 pack years. Hopefully though, we can get the guidelines changed to include the updates that Alex mentioned, and then we can get more people covered for screening. One of the other big problems, and like Alex mentioned, this is why we as an organization are just trying to reach out to communities and drive community-based awareness. Even though lung cancer has such a high prevalence in the population and has such a high mortality rate, it's actually one of the least screened cancers across the board, regardless of how common it is. Falls way behind breast, cervical, and colon cancer screening. So how do we actually go about getting folks screened? So there's a couple important things here. First of all, you need to talk to your primary care provider for a referral or a prescription to go get screened. I'll talk a little bit more about that in the next slide. In terms of finding local centers, most regional medical centers, if it's a large hospital or something like that, and a larger IHS hospital or clinic, they will typically have screening. They'll typically have screening facilities. You can also check with the ACA, the ACR, and see what they recommend. And then there are a couple other options that I'll talk about in the next slide. So one point that I didn't touch on before, but it's also a very important part, and this is part of the Preventive Service Task Force recommendation and also part of the Medicare requirements, is that you need what's called shared decision-making. So like I said, you have to work with a healthcare provider to get this screening set up. However, that doesn't have to be from a medical doctor. It doesn't have to come from an MD or a DO. It can come from a nurse practitioner, an NP, or a physician's assistant, a PA, depending on whatever's staffed at your local clinic. That's something to discuss with them. So even if you aren't immediately close to a doctor, other healthcare professionals can help you out. If you aren't sure about what kind of coverage you have, if you don't currently have a primary care provider, your closest clinic is a very good resource, or if your tribal office or reservation happens to have some sort of healthcare resource office or an outreach officer, if you can work with them to see if they have health advocates on staff, or if they happen to know of like some sort of resource line. These people are all on the patient's side. They're not necessarily healthcare providers, but they're people who are knowledgeable about the local community and who are really just there to help patients advocate for themselves and get the care they need in a way that works with their budget, finances, and the locally available resources. They're all assets to the patient, and it's a great way to make medicine more culturally appropriate. They'll also help with figuring out insurance enrollments and coverages down the road. But to step it back a second, shared decision-making is really key in this process, and it's something I wanted to touch on. There's a lot of fear that comes around cancer diagnoses. We had a cancer diagnosis in my immediate family a few months ago. And like the first reaction was like, what's next? You know, thinking that your life now has like a relative term on it. And fear is very powerful, but it takes both the healthcare providers, but also the patient. You have to want to get that care. You have to be willing to work with these other people who are invested in helping you get the care you provide. And that's a key part of the shared decision-making component. Patients have a lot of agency in this process. And so it's up to you to work with your family and friends and all those folks that are there to support you in your community to go ahead and proceed with treatment, because it's the best thing for you. So with that, in terms of what happens after screening, let's say your scans are normal. That's fantastic. You'll, again, like we mentioned, you'll get your next once a year screening. And hopefully it'll be clear again. However, sometimes scans are abnormal. Like we said, like you saw before on that CT, there was a sort of hazy patch that could be a bunch of different things. It doesn't necessarily mean cancer diagnosis right away. So this is where the next step of that shared decision-making comes into play. You'll work with your care provider, discuss with your doctor or your NP or your PA, whoever staffs your local clinic, to see about what the next steps may be. See if you can get a biopsy, figure out what this thing actually is. If your scans are abnormal and suspicious, so like we discussed before, if that nodule is growing with time, you know, like let's say you have a series of scans and it seems to be getting a little bit bigger with time, then you will need to probably take more concrete steps to figure out what's going on and see what treatment, if any, is needed. Also, since this is a discussion of lung cancer prevention as well as treatment, this is sort of rehashing a little bit of what we did in the lightning round. Bear with me. Sorry for sounding like a broken record, but you know, this stuff's really, really important. So we'll talk about commercial tobacco cessation. There's never a better time than now to start quitting. It's the greatest factor for lung cancer in the US. 80% of lung cancer deaths are linked to smoking. And no matter how long your pack year history is, no matter how much you're smoking right now, the benefits are nearly immediate. Your blood pressure will start dropping within hours. 2 weeks to 3 months after you quit, you'll actually start noticing your breathing improve. You'll feel like you need to be breathing less hard. You'll be able to, you know, do more effort with less difficulty just based on your ability to breathe better. 1 year after quitting, the risk of coronary heart disease is half of that of a current smoker. And you'll also have greatly reduced heart attack risk. And then 10 years down the road, the risk of dying from lung cancer is about half of that of someone who's been smoking through those same 10 years. One other thing that's really important, especially for the Native American and Alaskan Native population, is that relative to the rest of the United States, they have the highest rates of smoking versus other races. That includes both adults and minors, so in the 12 to 17 age group. So just for reference, in terms of the adult population, approximately 22% of Native Americans are adult smokers versus 16.6% for whites and 16.8% for African Americans. And that's a pretty big deal, especially when you take into account the relative portions of the population. That's a pretty big deal. And it's also key to remember, like we said before, that quitting smoking isn't just about you. If you can reduce secondhand smoke exposure to your loved ones or other folks that you live with, that will also reduce their risk of developing lung cancer. There are a lot of different options for quitting smoking. And like I said before, it's also really key to remember that quitting smoking isn't the end all be all. You need to also get screened. You need to be cognizant of your smoking history. And cessation is actually required by Medicare and Medicaid to continue in the screening program. So there are a variety of options for smoking services and cessation programs, things like that. I'll talk about that in a second. But just for you to be aware of the reduction that comes with smoking, in addition to the benefits I just mentioned, you'll be at 8% fewer risk for developing adenocarcinoma, 9% less risk for large cell, 11% for squamous cell, and 17% for small cell lung cancers. This is something we'll touch on in the next webinar, but these are a few different types of lung cancers, and you can have some fairly significant reductions across all those different types. So there are many different ways to pursue quitting. There's counseling, replacement therapies, medications. It really just depends on the path that you want to take, what you think will be best for you, and what you think matches best with your personal beliefs. The Affordable Care Act and other laws require insurance companies to cover cessation options. One other thing to be aware of is that within the Affordable Care Act, there was also the Indian healthcare provision. Part of that was the guarantee of cancer screening programs with the ACA. So that's also another very important facet of this discussion. And so in terms of the different program options, there are things like behavioral counseling. So that's you working with someone else. There don't necessarily have to be any sort of drugs or substances involved. It's more based on peer-to-peer interaction. There are also drug-based therapies, things like nicotine patches, gums, some other oral medications. And then there are other things that are sort of a a little bit bigger picture than peer-to-peer. There are financial incentives. There are alternative methods like acupuncture and hypnotherapy that isn't necessarily based on just person-to-person interaction and adaptation of your behaviors. So again, there really are a lot of options for you to find what works best for you and your personal beliefs. One other thing I'd like to mention is we're just wrapping up now. There are many lung cancer clinical trials. Again, touched on this in the lightning round, our first webinar, but clinical trials are a really great option in the flow of care. They can give patients access to experimental treatments, things to try different new therapies that are under investigation. So you're actually helping other lung cancer patients through your own treatments. And you're doing it in a way that's ethical. These trials are reviewed and consistently watched by ethical boards to make sure that the trials are being conducted in a way that's safest for the patient. It's not just about developing scientific data, it's about protecting patients first. There are currently about 500 open trials on cancer.gov. You can search through all of these. Some of these will be at different regional centers. So even if there isn't one particular trial of a particular type in your area, other centers may be offering other types of trials. And that's something to, if you're a little intimidated by that site or if it's a little opaque, that's another thing that you can bring up in your shared decision-making with your healthcare provider or with those patient advocates if you're just trying to take the steps to find a provider. Different trials also have different eligibility criteria. One other thing to keep in mind. So might be a variable like how old you are, or if you have a certain type of smoking history. These are things that are also folded into who is encouraged to enroll in certain clinical trials. So if you're not eligible for one trial, you may be eligible for another. Just because you don't match one doesn't mean it's the end of the options. That also includes more advanced stage disease. So things where they might not necessarily be treated a certain way may get a certain type of treatment under a clinical trial. So just to wrap things up, looking ahead at our next webinar, we'll be covering medical and clinical information on lung cancer. So like I mentioned before, we'll talk a bit about the different types of lung cancer, what it means to have one versus another. Talk about treatment options, so things like radiation, chemotherapy, surgical resection, or one other approach we take, which is the surveillance with time. Some lung cancers are lower grade than others, and it might not be the best time for you to get treated right away. These are all part of that shared decision making. And to round it out, the course of care. So how you'll work with different care providers at different steps along the way to make sure that you're treated properly. So that's about it from our side, unless Alex or Jeff had anything else they would like to add. Okay, yeah, so I think we'd love to open it up for questions if folks have any. And also thank you so much again, Misha, for the patience and working with us. It's a real honor to spread some more community awareness and get to work with your group.
Yeah, we are very happy to have you guys as well. I know I have learned quite a bit of information throughout this. We did have a comment that I'm hoping you guys see, but yeah, if anyone has any questions, please feel free to type them into the chat box. I did have a few questions going through that you may or may not be able to answer because I know they're kind of coming out of left field perhaps, but I am thinking that some people might be concerned, of course, about COVID-19 and lung cancer. And so just kind of wondering how the symptoms are different, if at all. And then, yeah, we'll start there.
That's a great question. I actually meant to address that. My apologies, but I think Jeff may actually be the best person to answer that if he doesn't mind.
Not at all. I think that's a really important question. So with the symptoms for COVID, those symptoms range quite a bit. And so you hear in the news about folks who have no symptoms and then ranging from very severe symptoms. But I think that where it overlaps with lung cancer certainly is when patients cough, and when that's their primary symptom. I think that lung cancer, typically you're not going to have a fever, and but to Misha, to your point though, with a lot of, sometimes if somebody has COVID and lung cancer, you'll pick, or if somebody has COVID and they don't even know necessarily that they have COVID and they get a CT scan, then you'll see you'll see what they call ground glass opacities. So basically that image that Winston showed you, you'll have some white blotches or hazy white grayish blotches, and which is characteristic of COVID and can be confusing for lung cancer. So I think that in this setting though, it's probably there, again, it's hard because some people have almost no symptoms whatsoever, but I think that typically, classically, we associate some fever and some of the other symptoms with COVID as opposed to with lung cancer. So.
Yeah, thank you. That is clarifying. So we only have a few minutes. I'm going to try and just answer or ask one more. So for any of you, how do you encourage or what do you say to patients or family members to get screened?
Oh, Winston, you want to take that one or?
Sorry, there's a little, could you repeat the question? I lost like a little bit of the first part.
Yep, so I'm just curious about what you would say to your relatives or to patients that you work with to get screened for lung cancer.
That's a great question. Yeah, also thank you, Anya, for the comments. And this actually might overlap a little bit. One thing that I mentioned or discussed with some of my friends in college, they grew up on different reservations around the country, but they mentioned that reservations don't necessarily have tobacco tax, and that can be one thing that makes smoking a little bit more frequent. So in terms of that, recommending for folks to get screened, especially with a recent diagnosis in the family, I would say that the fear really does make you not want to find out some things, especially as a loved one. I'm not even the person with the disease, and like part of me wishes that we didn't know. But to say that once you're aware of, I mean, well, first of all, if you get screened and there's nothing wrong, then you have proof that there's nothing going on. And that's a really, really nice feeling. And if you do get screened, if something shows up on your scan, again, it isn't necessarily lung cancer. There are many other possibilities. So it's not like getting screened will actually tell you that there's something exactly wrong right then and there. It's just one tool in a toolkit that's very important for you. Screening can also have benefits for other diseases. You can see things about the heart on some CT scans. So there's a lot of actually very useful information that isn't necessarily cancer related. So if you have the option of getting screened, if you have the insurance coverage right now, or if you're curious about it, it's more just about gaining that extra information to empower yourself and your family. That's kind of my suggestion.
Thanks, Winston. And then Misha, I wanted to add on a little bit to Winston and kind of your original question. So with COVID right now, screening can be challenging. So right now I'm at Massachusetts General Hospital, and earlier in the year, everything was just shut down because the entire city was overwhelmed by COVID. And so now that the COVID numbers are lower, people are doing screening again. So each region, it's different. So we encourage everybody to, stay safe first and foremost. But also, if your region doesn't have as much COVID, then and you qualify or you're eligible to get screened, we encourage you to get screened. Usually at this point in time, the clinics are, everybody's wearing masks, social distancing, everybody's taking everything very seriously. And so I would say, I anticipate, at least I can speak for the places I've been at, it's safe to get screened right now. But again, it's region by region, so.
One other thing to mention off of that, you shouldn't need to take your mask off to get a CT exam. It's just like a cloth mask. So it's totally fine for patients to keep the mask on pretty much the whole process. So you really don't need to lessen that amount of protection. And the same goes for the technicians at the clinic. Everybody should be able to leave their mask on for the duration of their process. And if you, like Jeff said, combine that with social distancing, you have quite good protection overall.
Thank you all for providing all of this insight. I am very grateful, and thank you to all of our participants as well for participating. If you have any questions, you can definitely reach out to the Cancer Equity team and we can connect you with some of the panelists here, or I can try and answer the questions for you as well. So yeah, we enjoy and appreciate you guys all joining us today. Thank you to all of our panelists as well.
Great, thank you.
Thank you, Misha.
All right, have a good afternoon, everyone. Thank you. Bye.